So next up we've got Oxford Community Trust. So my colleague Corinne Eastairs has been leading a piece of work across Midlands and East looking at Red2Green in non-acute settings. That could be community hospitals, mental health, doesn't even have to be bedded facilities. And so we've got Robbie, Dedi, who's the Deputy Medical Director, Sandra, who's the matron, and Bex, who's the clinical lead for OT, who's going to come up and briefly talk to us about their experience.
For asking us to talk. I'm Deputy Medical Director. I've been there about 6 months, so I just wanted to do a very brief one slide on my part, just to give a bit of introduction around Oxford Health. So we've got 6 community hospitals with about 150 beds. I went there and I've got to say it's probably been a bit of a journey for me actually. So I went in and heard about Red2Green, partly from West Suffolk where I'd worked recently before I went into Oxford. And actually thought about it as more of a length of stay type, probably a performance management tool. Got hung up a bit on the data and the processes, etc. Actually what's been a fantastic journey is just by thinking about Red2Green and the cultural change it's had an effect on within the community hospitals, a bit more discipline around doing morning MDTs and afternoon huddles, has made a significant difference to the staff and the patients, and that's partly why there's 3 of us. So rather than me talking about it, it's actually Sandra and Bex who've done all the hard work. It's helpful for them to talk to you about the experience, and particularly in relation to patients. We rolled it out in January and we've kind of concentrated on one area. So we've got 2 wards in Witney, and it's just really, if you're sort of thinking about it in the community hospital setting, because it's such a diffuse area, we thought we'd concentrate on one hospital, get it right there, and really sort of use a train-the-trainer approach. So Sandra and Bex were identified very early on as being real enthusiasts and using that enthusiasm to generate that with the rest of the staff, rather than it being a more top-down approach. And Sandra and Bex have done lots of sterling work in terms of rolling this out at Witney and then further across the community hospitals. I think it is very interesting. I've got an acute medical background, and working in a community hospital is quite different. And it's really, we've talked a lot about doctors, but most of the work that's been done within the community hospitals haven't involved doctors at all. It's been therapists and nurses, and actually even within an acute trust, one could imagine that, you know, if you are struggling a bit with clinical engagement, the clinicians are all the staff involved in that patient care. It's not just doctors, and really how to utilise their skills and use doctors not necessarily as the primary drive to do this. So that's all I wanted to say really from our point of view. Thank you very much to ESIP who've come in and really helped us try and drive this through. I'll leave it to Sandra and Bex.
Right, so small hospital, we are a small hospital. We are a 48-bedded hospital, 2 wards in the community. So we've got Linfoot ward, which has got 24 beds, 20 generic, 4 short-term EMU beds, emergency medical EMU beds. And the average length of stay before the project was about 29 days. When missed, 24 beds, 14 generic and 10 stroke, and the average length of stay is 31 to 42 days, depending on which pathway people were on. Medical cover is gerontology. They're there 9 till 5, Monday to Friday, mostly the junior doctors, the FUs and registrar. So we're nurse and therapy led. Therapy covers Monday to Friday with limited cover at weekends, and the nursing covers 24/7. And we have EMU medics available 10 till 8 every day, but they're only really for emergencies. So we started off with our 4 questions and what do people really need to know. We've got these posters up. It's still work in progress, very much work in progress for our patients, but it's a start for us. And we started very simply with our 9 o'clock huddles, social workers involved as well. Doctors did get engaged because they found it a really useful update from the day before. So yeah, so that's useful. And we do that Monday to Friday, nothing on the weekend. So we had, in the first month, we had 311 red days and 286 green days, and that's not including the weekends, so lots of red days. And we found that we can make our internal systems more efficient by focusing on specific tasks, which helps the clinicians prioritise workload. access visits and home visits are completed more proactively, and onward referrals and equipment ordered. We also very much started having expectation meetings with families.
I think I probably mentioned on a couple of the sort of tables that I was on that I think it was really easy, I think, before we started this, to blame other services for the fact that some of our patients couldn't move on. And I think, you know, it is fair to say, especially in Oxfordshire where we live, you know, care is very difficult. We're a predominantly rural area, and it's very difficult to get care. But I think for us, I think it was about making sure that everything could be done as far as we were concerned as professionals, and that we were being proactive and making sure sort of things sort of were done. And I think with regard to the sort of access visits and sort of home visits, something that we sort of developed on from there, and we have been doing actually even probably before that, is actually looking at patient discharge. And again, another conversation that I had was about some people were talking about sort of waiting on ambulances or being able to get patient transport. And whilst we're not patient transport, we're a therapy service, actually some of our patients could have a discharge home visit. So we've got a therapy vehicle that was donated to us by the local community, and it's wheelchair accessible. And actually, we sometimes don't need an access visit or a home visit. We could actually take that patient home, providing that we don't envisage there being any major problems, but we can assess them once they're home, and then actually you take away those sort of issues with transport. I think the other thing that we do as well is we'll often meet carers there, so we can actually sort of transfer care plans across sort of straight to some of the either community therapy teams or the home care teams that we're working with.
So one of our challenges was getting staff to prioritise the huddles as attendance daily, but we've got some key players in that, and we're gradually winning the others over. We found that therapy, there's been some time constraints with that, identified through making our systems more efficient, and completing paperwork is also an area where it falls off the agenda when people are busy. One of the things that we have found is because we end up with lots of patients who got to the end of their journey and they're actually ready for discharge, we needed to start thinking a bit more creatively about how we were going to discharge some of these patients. So we discussed it with our head of community hospitals, and we created some virtual beds. So we've been able to take a few patients home because they've needed very limited input for a short time, and it's about creating, making them more confident about being discharged. So we haven't closed the beds, but we haven't got the patients in the beds. They're in their own beds, but we're sending our nursing staff or our therapy staff out to provide that care or to deliver the therapy at home and build on their confidence, and then we can discharge them. One of the other things we've done is working very closely with our community therapy teams and our integrated localities, district nursing and hospital at home and such like, to take some of those patients that have been in hospital a long time. We had one lady who'd been in hospital since June last year, and she kept getting to nearly ready and then the care wasn't available, and then she'd get another urinary tract infection and become really septic, and then we'd go back and she'd be off the list. And so what we did was we took her home, we worked with her family to manage the care that she needed, and we've actually managed to get her home successfully, and she's been home over a month now with no other admissions, and she was very anxious about going but very keen to go.
So another example of some of the things we've been doing, we had a youngish lady who was, well, she's young, she's in her 50s, who ended up with a very long hospital stay. Was very acutely unwell, and again I think we talked about it in some of our groups. She'd been told by the acute hospital that she would spend at least 6 months in hospital. So the challenge was obviously when she came to us, her expectation was that it was going to take her 6 months. She had already spent 3 months in hospital because she had become very unwell and spent some time on ITU and therefore became very deconditioned. But so when she came to us, she was expecting to be with us for at least three months. So something again that we sort of started up was setting expectation meetings. So, you know, we actually got everybody in, her husband is included, and had that conversation with her about actually this is what the plan is, what, you know, and talk to her about what her goals were and what she needed to do. And obviously just tried to sort of reset her thinking really about how long, you know, she should be in hospital. Following that conversation, she actually probably went home about 2 weeks later after a very intense therapy and an agreement that we would provide therapy to her. So she would come to us, to our therapy team. Again, this is one of the beds that Sandra's talking about. So that bed wasn't filled. Our therapists were able to provide this lady with physio and OT, but it was done in collaboration with the community therapy service. So they came and did joint visits into the hospital. So they did in-reach, we sort of did outreach, and then they took over her care or the therapy needs. She didn't need a care package. That did make it obviously less complicated. But we do have another example where we did provide care, which was challenging. We had our nursing teams and therapists to sort of help provide care and to try and just get this patient out, because being in hospital for this particularly elderly frail lady was not a good thing. But that did have that sort of had other challenges. Probably explain further.
So so now our length of stay is reduced down to 16 days across the generic beds and 20 days with the stroke, and our communication with our families is improving, so you know that it's a win. And we've got a much more solution-focused discharge planning, so hopefully helping the acute needs patients through the system as well. Thank you.